Good morning and good afternoon, everybody. I am Roger Strode. I'm a partner with the Chicago office of Foley and Lardner, and I would like to welcome all of you to the recent installment of our Access to Capital webinar series. This has been a really successful series for us, and we know that a lot of you out there have enjoyed these webinars. This is the Access to Capital 2014 year in review and a look ahead to 2015. We think that today you're going to really enjoy our group of panelists, and I'm going to introduce our panelists in just a moment, and I'm going to tell you a little bit about what we're going to talk about today. But before we start, I wanted to go over a few housekeeping tips. Today's program is going to run for 75 minutes, and we're going to apply for one general CLE credit for the program. All New York, New Jersey, and Kansas attendees applying for CLE credit must fill out an attorney affirmation form and write down the course code that's going to be given to you during today's web conference. It'll be given to you later on in the conference, so no cheating. Electronic questions can be submitted through the broadcast by clicking on the Q&A tab at the bottom of your screen. And what we'll try to do, if we can, is work them into the panel discussion. And if we can't work them into the panel discussion, we promise to attempt to get to all of them during the Q&A session. If for some reason your question doesn't get answered, please feel free to send any one of us an email and or give us your email address, and we promise that we will get to that question. If you're in need of CLE credit today, you're going to want to enter the 4-digit code in the poll question on the screen after it's announced later in this panel discussion, and then you're going to press the submit button. And I'll give you that code again in a while. Again, if you're looking for CLE credit for the session, please complete the polling question by entering the code that was just announced, or that's going to be announced, I'm sorry. And the polling question is going to remain open briefly. For those seeking Kansas, New York, and New Jersey CLE credit, in addition to the polling question, you're going to need to complete the attorney affirmation form and return it to Zuleika Rahim at Foley.com immediately following the program. We will give you that email address. And a copy of the form can be found in the resource list widget. All right, so let's knock this off. Our panelists today are going to include my partner, David Bannard, in our Boston office. David is an experienced bond lawyer, and he served as bond counsel to quite a number of healthcare institutions, as well as to airports and other issuers. He's been counsel to borrowers and underwriters, as well as in-house issuers counsel on many transactions. So we're really pleased to have David here today. In addition, we have from the PFM group, Chris Doyle. Chris is managing director in PFM's Boston office, and she has over 25 years of experience in public finance. She advises healthcare and other nonprofit clients on financial and capital planning, development and implementation of balance sheet strategies, financial risk management, evaluation of financing strategies, and optimal financing execution. She's worked with a variety of healthcare organizations over the course of her career, including health systems, specialty hospitals, community hospitals, and children's hospitals. Chris has a BA from Harvard and an MBA in finance from Columbia. Chris is a very good friend of Foley and Lardner, and we're really pleased to have you here today, Chris. In addition, and finally, we have my friend Jim Maloney. Jim is managing director and co-head of Cain Brothers Tax-Exempt M&A Group. Jim's been with Cain Brothers since 1995 and has more than 25 years of experience in healthcare finance and real estate. Jim advises hospitals, physician groups, and managed care clients on a wide variety of merger, acquisition, affiliation, and joint venture transactions. I've had the pleasure of working with Jim on a number of transactions, and Jim knows how to run a deal and knows how to bring together the parties to a deal. So I think today you're going to be very pleased with what you hear. What we're going to do is focus a little bit on what happened to the M&A and financing markets in healthcare in 2014. Jim is going to bring you the perspective of a very experienced healthcare investment banker, and Jim will look at transactions among providers, hospital-to-hospital deals, provider-to-payer deals, physician-to-hospital deals, and some of the different deals that we saw in 2014. And as you'll know, 2014 was a lot different than 2013. We had in 2013 an extraordinarily robust hospital M&A market. And the market, in my opinion, cooled down somewhat in 2014 for various reasons. And Jim's comments should be balanced against those of Chris Doyle. As Chris will tell you, we're right now in an unprecedented period where interest rates are about as low as we've ever seen them. And some of these rates and in this environment, we think, have changed the way M&A deals and affiliation deals are going to be done, and have been done and are going to be done in the future. So Chris is going to give you that perspective. They're both going to give you the perspective of what to look for in 2015, and along with that, my partner David Bannard is going to spend some time talking to everyone about the changes that we saw in some of the legal aspects around tax-exempt financing. Most especially, David's going to spend some time talking about the recent changes to Revenue Procedure 9713 around the management of tax-exempt bond finance facilities. He'll spend a little time talking about the MCDC initiative and also the municipal advisor role. So, guys and gals, with that, I'd like to kick it off, if I could. And Jim, I'd really like to start with you. Given your broad perspective on deals, could you kind of talk a little bit about the deal environment in 2014 and some of the reasons why maybe you thought the market was a bit soft, at least to my perspective, it was a bit soft. And if you could touch on some of the significant deals in 2014 and interesting deal structures, that would be most appreciated.
Okay, thank you, Roger, and good afternoon and good morning to everybody that's on the phone. I think what we'll, as Roger kind of laid out a nice overview of our discussion, when you think about access to capital, it's both demand for capital, what are people investing in, and it's also sort of the price of capital. And I think Chris will walk through and explain what we're seeing in this sort of the dynamic around the cost of capital and some of the drivers for demand. What I'll focus really on are some of the big themes that are affecting the provider side of the healthcare sector, which is really the part of the healthcare industry that I focus on at Cain Brothers. And I think there's a couple big themes that influence most of what we're seeing in terms of transactions. The first is the preparation for a transition from fee-for-service to value-based reimbursement models. I think with a few exceptions, in most markets in our country are still dominated by a fee-for-service model for the payment of health care. But I think most people recognize that model's got a pretty short half-life. The speed with which reimbursement models will evolve and change will vary by the size of the markets and by the geographic region and sort of by the makeup of the payer community. But I think I think a lot of what we're seeing are healthcare provider entities and payer entities preparing for a different reimbursement environment. And I think that influences what we'll talk about in terms of transaction trends. The second is related but a little bit different, and that is the preparation for a population health model. And that is really more than just providing care to people, but it's building the systems, the tools, and the infrastructure necessary to be more than just a provider of a medical condition treatment, but it's really improving the health and investing in the health of a defined population. We're still not there in most places, but I think we're seeing pretty strong momentum for people laying the groundwork to be prepared for that on a go-forward basis. And then lastly, I think we're seeing a big influence on consumerism, and there's a lot of dimensions to that which we'll touch on. There's transparency, there's tools to enable individuals to be more proactive with their healthcare decisions. It's forcing physician groups to think differently about the relationship with patients. It's forcing healthcare systems to make different kinds of investments in the systems and tools, and we'll talk about some of those trends as well. So let me switch now to a view about community health systems. What we're seeing in the community health systems, and this is primarily focused on the not-for-profit component of the healthcare industry, there's a couple big challenges that they're really wrestling with. And the first is this transition from fee-for-service models to more value-based reimbursement models. And then the second is building the tools and systems to really manage risk to the extent risk is transferred to the providers. And I think those two key themes are evident in a lot of the deals that we see. Right now, what we're seeing is most of the hospital activity is really centered around achieving economies of scale. Sometimes those are very straightforward transactions. We're working on a hospital affiliation transaction with a relatively small hospital in the Central Valley of California. They're going to join a large not-for-profit healthcare system, and really for them, it's getting the economies of scale. It's being able to get the efficiencies from the back office functions, et cetera, that will allow them to reduce the cost of their organization to be able to provide the quality of care and make the necessary investments in their health system to serve patient needs on a go-forward basis. Roger and I worked on a transaction last year in Phoenix where it was the combination between John C. Lincoln and Scottsdale Healthcare, and bringing those two organizations, which really had complementary delivery systems in a single market, was enabled them to remove a lot of overhead costs and be much better positioned to provide care in a more cost focused environment on a go-forward basis. So these economies of scale are really driven by the cost side, much more than in the 90s up until probably 2006-07. A lot of those transactions seem to be more motivated by revenue enhancement. There's very little discussion about revenue pickup in deals that we work on today. It's mostly around bringing cost systems into a more rational level. I think most of that focus is local, so it's bringing local scale, but we're starting to see more discussion around regional geographic contiguous building contiguous geographic systems. A good example of that is a transaction we worked on last year in Madison, Wisconsin. Meritor Health became part of Unity Point, which is a very large not-for-profit system that has the bulk of its system based in the state of Iowa. It's now moved into Illinois. It's moving into Wisconsin. I think the Unity Point view is one that we see with a lot of the larger regional systems. Is they have to be more than a single state. They have to be in the important MSAs that have regional relevance to where their core business is. And I think we'll see more of that on a go-forward basis. One of the big challenges for many hospitals today is the necessary investment in IT systems and specifically electronic medical records. The big two, Cerner and Epic, are jaw-droppingly expensive investments and really beyond the reach of most smaller healthcare systems. One of the things that's kind of interesting is we worked on a transaction earlier this year where the cost of transitioning their hospital into either a Cerner or Epic platform was going to be, something in the neighborhood of 30% of what it would cost for a hospital to do it all by itself if they did it as part of an affiliation. And so getting the benefit of organizations that have made that investment have created all the build out on those is quite helpful. I think one of the reasons that Roger referred to a slowing of transaction activity is that there's been a lot of focus on integration with physicians, and that takes lots of different forms. But there's a lot of effort by healthcare systems to invest in either directly with acquisitions or in those states like California that have corporate practice through other models like foundations or other kind of integration tools to really bring the physicians in line. And that's all about the transition to managing risk. If you don't have an effective affiliation with the right physician partners, it's very difficult for a health system to really manage risk. And the last thing that we're seeing is we're seeing an increasing amount of interest by health systems to move into the payer specter. That's a really tricky balance. My office is in San Francisco, the California landscape, at least in LA and San Francisco, is heavily influenced by Kaiser. And if you talk to most providers in LA or San Francisco, they talk about preparing to or figuring out what they need to do to compete effectively with Kaiser. And what we're seeing is an increasing number of those health systems moving into the payer side. So Sutter is getting a Knox-Keene license, which is the license you need to bear risk and have an insurance product. Adventist Health is, Providence is. So a number of these bigger systems are starting to move at least partially into the payer side. It's a very complicated strategy because it puts you in competition with your big payers, but it's something we're seeing more of. On the payer side, I think the payer side is a pretty fascinating area. And the real challenge for payers is how do you manage risk and manage care? And I think one of the things we're starting to see is the relative control of health information shifting. And that could have long-term implications for payers. So one of the strategies that we're seeing is payers seeking to maintain continuity of coverage between the various parts of the healthcare insurance markets. So in states that have gone through the Medicaid expansion, you've got commercial insurance, you've got Medicare, the Medicare Advantage product, you've got Medicaid products, and then you've got these exchange products. And a good example is an announcement that was made on Monday is Blue Shield of California announced that it is going to be acquiring Care First, which is a Medicaid HMO in California. And I think a piece of that is to make sure that there's continuity of coverage. As the Medicaid expansion moves the poverty level up, patients move between commercial insurance to Medicaid expansion to exchange products depending on what their job status is, and payers want to have connection to those patients regardless of the type of insurance they have. And so I think that'll be a theme that you see, especially in those states that have elected for the Medicaid expansion. A lot of interest by payers to figure out how to be more directly connected to the provision of care, and we're seeing, payers look at acquiring both healthcare system providers and also physician providers. And then lastly is an interest in really building high-quality narrow networks. And I think the Vivity announcement by Anthem earlier this year in Southern California is a good example of that. They've created a network of very high-quality hospitals that typically haven't been well coordinated together. They're competitors, but they're in sort of disparate parts of the LA market. And they've built that model to begin the early stages of building a narrow network. We'll see how complete that narrow network gets, but I think that's a theme that I think we'll continue to see. On the physician side, I think the big challenge for doctors is building an organizational model that's attractive to be able to recruit new physicians and being able to capture what I call the systemness that allows for control of the economic power in population health. And what I mean by that is I think the provision of care in a hospital bed or provision of care in an exam room will increasingly become a commodity. The value that's created in the healthcare system or captured in the healthcare system is that portion of the healthcare system that figures out where to provide the patient care at the lowest cost setting that delivers the best quality outcome. And that's a really complicated, puzzle to try to solve. Physicians have a difficult time, most physician organizations have a difficult time being in the driver's seat in that systemness because they're not of the scale that allows them to make the investments in IT and all the systems that you need to do that. And so as a result, what we're seeing is a lot of physicians joining directly or indirectly healthcare systems. We're seeing mergers and consolidation in the physician world into single specialty groups or multi-specialty groups. And we're seeing a lot of pressure on physicians given the reimbursement environment to try to figure out better ways to reduce their cost of care through physician extenders. And then, the other big area is in post-acute. I think post-acute is one of the topics that we may talk a bit more about today. One of the fastest growing areas for Medicare cost-wise is post-acute care. It's also more profitable on average than acute care is, and it's very poorly organized in most markets. And we're spending a lot of time with clients looking at ways to figure out a better way to make linkages between the acute care world and the post-acute world to be able to deliver quality, low-cost service as you move through that spectrum. What the post-acute world is worried about is being connected to the payer streams, and if we finally do make that leap into bundled payments, where the hospital gets paid not just for delivery of the acute service, but delivery of the whole spectrum of service, then the hospital becomes a payer to the post-acute providers. And so linking up with the right acute provider can be really important. Figuring out what set of post-acute assets you need to have in a market to deliver the highest quality, lowest cost care is important, and it's especially important for LTACs and inpatient rehab facilities, which tend to have a higher cost structure than the skilled nursing side. The last area that we've seen a lot of activity in is in the academic medicine area. Academic medicine is characterized typically by having a relatively high cost and having rigid models. Part of those models are, sort of self-imposed, but some of them are outside their direct control. So there's a couple different types of strategies that we've seen the academic medicine world engage in. One is to connect their academic organization with a larger healthcare system. I think the Kentucky One transaction with the University of Louisville is a good example of that. Kentucky One is a large healthcare system. The University of Louisville Medical Center was able to become part of that and therefore get access to a larger pool of patients so that they could provide that higher-end tertiary and quaternary care and be part of a bigger system. I think one of the things that you'll hear more about in the future is the academic, the schools of medicine and the related academic medical centers figuring out how to capitalize on the value that is related to the creation of physicians. Physicians are a shortage and that shortage will become more acute over the next decade. And I think figuring out how to capture the value of that physician creation will be important. Some of the schools like University of Wisconsin, University of Washington, University of North Carolina have done a really good job of building big primary care networks, and that's one approach to doing that, but I think there's going to be others. And I think what you'll see is people using the brand value of these high-quality academic medical centers to forge either formal affiliations or contractual linkages through ACOs and others with health systems to be able to build a more rational care model that can, capture that higher end service at the academic side, but be able to participate in a broader network of care. So that's just the quick overview of what we see are some of the strategic drivers for transactions and therefore demand for capital. And I think I'll turn it back to Roger to introduce Chris.
Thanks, Jim. I appreciate that. We're going to come back to you shortly to talk about how you think this translates into deal flow and the different types of deal structures that you guys are looking at for 2015 and beyond. But before I do that, Chris, I'm hoping that you can give us your perspective on the types of financing structures that you and your colleagues have seen this past year and how they impacted deals and deal flow. I think that'd be very helpful to everyone. And again, when we're done with that, we're going to toss it back to you and to Jim to talk about what you think in 2015. So if you can spend some time talking to us about the interest rate environment and what you think the impact on deals has been in 2014, that'd be greatly appreciated.
Sure. Thanks very much, Roger. What we've seen over the course of 2014 is it's really been what we've been thinking of as a seller's market. It's been much more diverse than we've seen in the past, meaning that while there's been decreased issuance in the tax-exempt market, there's been very strong lending in the private market, and the decrease in the tax-exempt public market, but there's been very strong lending in the private tax-exempt market. And in addition, many borrowers are turning to taxable debt as well. We're seeing a lot of taxable issuance over the course of the year, and that's really driven both by conditions in the market as well as by some of the strategic activity that Jim was describing. In terms of the overall reduction in tax-exempt public supply, I think overall in the muni market it's down about 10% for the year, and then in terms of healthcare supply for the year it's down about 25% or so. There are still investors looking for opportunities, and so that's contributed to reductions in rates and also pretty significant reductions in credit spreads for healthcare issuance. In addition, there haven't been any events or kind of events that have caused significant outflows from the muni funds, such as we saw in sort of the summer of 2013 or sort of late in 2010. So as a result, over the course of 14, inflows have remained strong on the tax-exempt side. There's been a tension that we've seen with our healthcare clients between being very eager to secure low-cost debt that they see in the market, whether it's on a tax-exempt or a taxable basis, and getting the flexibility that they think they might need for their future strategic objectives, some of which Jim was describing and we'll go into a little bit more later. So that people are recognizing the value of that flexibility, but they also see that this market with these low rates is a significant opportunity. So some of the structures that we're seeing are really trying to balance off that low cost desire with the flexibility. We'll talk a little bit about some of the very, very loose and easy terms and conditions that we're seeing coming out of structures that kind of meet some of this balancing. In addition, we're seeing borrowers continue to look for risk reduction in their capital structure. They're facing a lot of risks in the healthcare industry, and they're really looking on the capital structure side to try and mitigate some of the risks that they might face, whether it's from banks or other aspects of the market. And so that's been another important theme over the course of the year as we've looked at the type of structures that have come to market. In terms of taxable debt, we've seen people being interested in it for really a variety of reasons. The absence of use restrictions is very, very significant. So as entities are looking to restructure, join with other organizations, the flexible use on taxable debt has been an important driver over the course of the year in that, and it really makes it more attractive than tax-exempt in that context. In addition, beyond flexibility, we're seeing that because there's been the volume of taxable debt has been higher, it means that the investors in taxable debt have become more used to evaluating and thinking about the structures that a nonprofit healthcare entity might be looking for. So in other words, where it used to be we would only see a make-whole call on taxable debt, now we're sometimes seeing a 10-year par call, such as a borrower might be used to on the tax-exempt side. And so taxable investors are kind of getting familiar with and getting used to that potentially being a feature that might be in a taxable structure from a nonprofit healthcare entity. In addition, those taxable investors it's becoming a deeper base. So it used to be that you'd really see the institutional investors for tax-exempt debt would sort of move over and maybe buy some taxable debt if one of their if someone that they were invested in was coming to market with taxable debt. Now we're seeing much more greater depth and variety of investors being active in the taxable market, and it's not just the institutions that are traditionally involved in tax-exempt investing. That's led to many borrowers having more in-depth and I would say more frequent and robust disclosure processes as well. We're also seeing, given the low rate environment, another structural aspect. We're seeing a really extended maturities. Some issuances out to 40 or 50 years, and there was even the example of the Cleveland Clinic going out with a 100-year taxable borrowing, and at very low cost, and obviously having a lot of flexibility in terms of those funds as well. Obviously, refundings have been pretty robust over the course of the year, and even given negative arbitrage, rates are low enough that some advanced refundings have become warranted by some organizations as well. One thing we mentioned earlier was loosened terms and conditions, and we're really seeing that across the credit spectrum given the lack of supply in the market, so that we're seeing really easier and fewer covenants in supplementals, or refinancings to take out tougher covenants and put in less restrictive ones. Absence of debt service reserve funds, even down into BBB type rating categories, and either no mortgages or pretty narrow mortgages in cases where they might be required. When we talk to institutional investors about this, they're disappointed and frustrated by this, but really the need for paper and for investment opportunities has taken precedence, and means they're willing to sort of swallow these loose terms and conditions. We're also seeing that with this type of restructurings and M&A activity, a lot of new MTI or master trust indenture structures coming into play with very, very light or almost no security and covenants in the base MTI, leaving the possibility for any additional covenants in supplementals. That's historically been obviously that's a structure that's been in place for a while, but it's really a shift we're seeing where the base MTI has no or very light security. In terms of the floating rate market, we'll just focus on that for a minute. There's obviously been much diminished issuance of floating rate debt over the course of the year, given the rate environment. And what we're really seeing borrowers looking for are to diversify and to lower the risk profile in their variable rate portfolio. In particular, looking for variable rate products that will reduce or potentially eliminate put risk has been an important consideration for those that are entering the floating rate market. And there have been some structures that either mitigate or to some extent reduce put risk that borrowers who either want to keep variable rate debt that they already have and perhaps change the structure, or who are perhaps managing to a percentage, a fixed variable policy percentage that they're seeking. Things like floating rate notes, whether they're issued on a public or a private basis. Window variable rate demand bonds is another structure that helps to try and mitigate some of that put risk as well. In terms of the private lending market, just to spend a minute on that, we've seen that be very, very strong over the course of the year. Lender interest is deep and pretty considerable and quite competitive. We're finding that that lenders prefer to lend under this in a direct fashion rather than offering enhancement through a traditional letter of credit or standby agreement. And that's related to the banking regulations that they're subject to, and it makes it a more preferable structure to them. That lender base we're finding is pretty diverse, with national banks and insurance companies, but then also community and regional lenders being quite competitive as well, in particular for lower rated credits and smaller borrowings. so that those local and regional lenders will tend to go out farther and have more relaxed terms and conditions for those type of more regional borrowings. In terms of disclosure in the rating agencies in this market, it's quite important to, we think, to be very mindful, for borrowers to be very mindful of their EMA and other disclosure requirements, and also to be communicating with their rating agency partners even if these type of borrowings aren't rated. These deals tend to be highly negotiated, and so the negotiations are quite critical, and we've just highlighted on the right-hand side some of the typical conditions that are very important to negotiate in a favorable fashion on. To the extent that these aren't negotiated well, these type of structures can create additional risks rather than mitigating risks. So we think that it's extremely important to pay attention to all of those provisions so as not to expand risk. We'll go to the next slide, Dave. And basically what we're seeing here in terms of municipal flow, as I mentioned earlier, is we haven't had any points through the year where we've had the outflows that on the next slide we've seen in the past, considerable last summer, triggered by a combination of comments from the Fed chair, bankruptcy in Detroit, and so on. And so this year really haven't had any of those kind of event-driven outflows. And as Roger mentioned in the beginning, I mean, really, obviously, very significant low. We're almost at the low point for rates, and as I said, that's really been driving a lot of the market activity that we've seen on the fixed rate side. Why don't we go to the next slide with the history of the credit spreads? And again, we'll see, obviously, credit spreads are not returned to their pre-crisis levels, but they've declined considerably over this course of this year, so that triple B credits are really have very excellent access to the market at much modified credit spreads as compared to the last 5 or 6 years. So Roger, I'm going to turn it back to you.
Okay, yeah, thanks very much, Chris. It was excellent. What I'd like to do for the next 10 to 12 minutes, if we could, Jim, and can you and Chris, and we can take up to probably 20 minutes, but can you guys give us your perspective on what deal flow you think is going to look like in 2015, given what you're seeing going on right now, and specifically, if you can focus on, in the past, Jim, for example, we've seen that a lot of the reasons for deals is you've got smaller hospitals that don't have the capital, they don't have the access to capital, they need money, et cetera. Do you still think that there are a lot of those types of deals out there? Also, do you think that Chris, that the interest rate environment is going to spur on additional deals as well? So if you can kind of give us your perspective on that, that would be greatly appreciated. Jim, if you could maybe jump off on that one for us.
Sure, Roger. So we're expecting to see a continued period of very robust transaction volumes in the hospital consolidation world. So health systems, I think, are going to continue to be very active. What gets reported kind of sometimes ebbs and flows a little bit, but I think the level of discussion today is probably at least as high as it's ever been. So, and I think that will continue for the next several years. I think there's still a large number of smaller systems that really don't have the scale to be competitive in the long run as independent entities. They'll ultimately all become part of some larger system, or most of those will, in most markets of size. I think what you're also going to see, though, is once health systems feel like they've got the big blocks in place, meaning that they've done the affiliations necessary to have the hospitals in the correct locations, there will be an increasing amount of conversation around how to really align with physicians, and some of those transactions aren't as apparent as the announced hospital combinations, and how to align with payers Sometimes those payer arrangements are obvious, like in the example of the Vivity announcement with Anthem, and some of those are less obvious and are more the construction of narrow network models that can start to really change the landscape of the reimbursement and market share models. An example is what Providence Health has been doing in the Seattle area. Once they merged with Swedish, they really got the big blocks in place that they needed for their King County strategy, and then their focus has evolved more on the physician side. They did an affiliation transaction with Pacific Medical Centers, which is a large, prepaid physician model, and they are now beginning to go directly to employer groups, offering substantial kind of narrow network discounts for being the preferred provider with large employers in the area. And I think that you'll see a lot of that. So we're expecting a very busy multi-year run. I think a lot of the focus is local market to get to the right local market models, and then I think you're going to start to see that the creation of these larger regional models will start to evolve, and I think it's the geographic proximity of major MSAs that will define whether or not those health systems are more valuable together or apart. I think we're beginning to see a lot of horse trading, so to speak, of large health systems that want to get bigger, but they're trading markets away to have the resources to invest more heavily in the markets that make more long-term strategic sense for them. And I think you'll see that, across the tax spectrum, both not-for-profit and investor-owned are going to be engaged in those kind of deals.
Jim, in that regard, a while back, that a lot of the conventional wisdom was that large health systems and that this country, that the evolution of the healthcare system industry in this country is going to start looking very much like what happened with the banking industry in this country, that there's going to be such a consolidation among health systems that you're going to be looking at essentially large regional systems with revenues of nothing short of at least $4 to $5 billion, and probably topping that, and what that's going to mean is really the demise of the standalone community hospital. Is that still the thinking, that we're going to have 10 to 12 large regional systems in this country, and that to be relevant to the market, whether it is to physicians or whether it's to payers, employers, et cetera, that you're going to have to be a system with at least $5+ billion in revenue?
Well, I don't think my crystal ball is sufficiently clear to tell you what the revenue number needs to be, or exactly how many of these large, multi-regional systems are created. But I think directionally that logic still is very good. I think if you look at the big, like Kaiser as an example, Kaiser needs a pretty large population to make their fully integrated model work properly. Probably in the neighborhood of 200,000 to 300,000 members for them to make their model work properly. That obviously can work well in a San Francisco Bay Area, or a market like, you could kind of have a comparable arrangement in a market like Phoenix or Dallas. But in smaller communities, there's a different model that will be developed. And I think one of the things that we're going to really wrestle with for the next 3 to 5 years is the relationship between the economic logic of constructing the right delivery models and the antitrust implications and pushback from the FTC about that. The truth is, the healthcare industry has a pretty bad track record of delivering value to consumers through consolidation. It's not universally bad. I mean, there's some examples where you've got highly concentrated markets that have done a really good job. For instance, Benefice in Great Falls has a pretty good track record of reducing the cost, despite the fact that they've got a near monopoly in that market. But I think that's an exception. And to get to 12 large systems around the country, it means you've got one or two providers in most major markets, and that's inconsistent with current FTC policy. So that's going to be a real battle, and I think healthcare systems are going to have to prove empirically that they not only can reduce costs, but actually do reduce the cost of care and improve the quality of care through these combinations for us to get to that level of consolidation.
And don't you think, and I want to turn it back to Chris here in just a second, don't you think, Jim, that much of that can be solved with this focus on value-based reimbursement and population health management as opposed to volume-based and fee-for-service?
It can be. I think it can be, and I think it hopefully will be. But I think it takes that's got to be the focus of the systems that get created, because if you go to you pick up Boise, Idaho, which has had some fair amount of news around antitrust issues, that's really a two-system market. That's a pretty stable place. I don't think that market goes to a one-system level. But those organizations, when you go from a 3 to 2, you got to really prove that you're going to be delivering value for that ability to achieve cost efficiencies. And I think at least the FTC has some degree of skepticism about whether that's really the motive, and B, what the outcome will be.
Interesting. Chris, could you give us PFM Group's perspective and your group's perspective on what you expect to see in 2015, both with respect to financings and its impact on M&A transactions?
Sure. I think that we're also seeing the type of accelerated M&A activity that Jim is describing, and that's going to be really driving and shaping the type of transaction flow there is in 2015, so that we're thinking in the short run, people are still going to be taking advantage of refinancings and taking advantage of the rate environment to the extent that they can, but also really looking to balance that off against any kind of affiliation or M&A discussion that they anticipate they might be involved in. So again, going back to the point about trying to preserve some flexibility while taking advantage of, at least for the first few or several months of the year, likely to continue to be a low interest rate environment. We think that the taxable debt will continue to be attractive for that kind of balancing, as well as potentially some increase in the amount of, gradually over the course of the year, perhaps increased activity in the variable rate market. Again, as people look, potentially as rates might rise, and also as people look to maintain some flexibility. I would also say, though, and Jim might have seen this too, is that a lot of the activity we're seeing around affiliations and joint ventures of different types have not necessarily involved a full integration of capital structures. And so, as a result, we're seeing providers looking for opportunities to find partners that are at various levels of depth. Maybe there isn't a complete and total integration and refinancing of all debt that would lead to a variety of transactions. Instead, there are different types of coordination activities that don't necessarily impact debt in the short run, or even in the medium run. So from that point of view, that's that variety of affiliations and variety of joint ventures is, we think, is been a pretty important piece of the M&A activity and is likely to continue to affect it.
Hey, Chris,
Mm-hmm.
let me add a point to what you just mentioned, and I think it's one of the good things about the current capital market is the interest rates are very close to zero, but it's also a bad thing when you look at what it would cost to refinance tax-exempt debt that's still subject to call protection. And we've had to do a number of structuring models around that very issue because sometimes even in a not-for-profit to not-for-profit combination, the cost of getting to a truly integrated capital structure is prohibitive because to defease using acquisition financing, electing the acquisition financing treatment to refinance debt has the negative arbitrage in the defeasance escrow is so large that it adds a significant amount of cost, and so many systems are opting to just defer that till they get either closer to or really to the call date because you've got a pretty limited window to exercise that acquisition financing election.
Mm-hmm. Absolutely,
and
I agree, Jim. Mm-hmm. Yep.
And I know, this is Roger, I know that last year I worked on 4 different hospital affiliations, and in each one we retained, at least initially, the separate obligated groups for exactly that reason, that the timing of trying to refinance and completely refund the debt, it didn't fit well within the transaction structure, and in many of them we were able to, because we retained the independent and the separate obligated groups, there was no need to go back and seek the consent of the bondholders of the master trustee to do the transaction. And now what we're seeing, and Chris, I don't know, maybe you're seeing this too, now what we're seeing is with interest rates falling and with the better interest rate environment and some of those call dates settling in, now we're seeing those transactions that were closed last year looking at doing complete refundings.
Mm-hmm. Yes, I agree with that. That even in the face of some negative arbitrage, that both marching toward those call dates combined with a continued decline in rates means that to some extent what were initially kind of prohibitive kind of entry costs, if you will, are being looked at differently. And also to some extent we're finding that partners, it gives them a chance to sort of step into a relationship in certain ways without necessarily putting everything on the line, if you will. So to some extent, certain types of governance and other organizational relationships can be sort of worked out in that interim time as a non-market consideration.
Roger, this is Dave. I'm going to jump in on that one because one of your examples, and I won't name names on the call, but I'm working on exactly that right now. We expect to. It was an affiliation between 2 health systems that closed last October. The financial close is expected to be a couple days before Christmas. They're going to refund all of one of the obligated groups, one obligated group's outstanding debt, and they use a fair amount of taxable debt, and I think that kind of goes to some of the themes that we've been talking about, that taxable debt rates are low enough and it's well enough accepted in the market that they're able to basically take out bonds that are not advance refundable with taxable debt, and then use tax-exempt debt for a number of other purposes to fully integrate and ultimately to merge these 2 systems together.
Thank you, David. And while I have your attention, I think we'd like to at this point kind of veer off course just a little bit and talk about a few of the initiatives that the IRS and the SEC have put in place with respect to tax-exempt debt financing. And David, could you spend a little bit of time? I'd first like you to talk a little bit about the changes to Revenue Procedure 9713 and the types of the terms and the changes to the terms and financial structures that the IRS is now allowing for management contracts of tax-exempt bond finance facilities. And then maybe you can talk about the MCDC initiative and the municipal advisor rule. And then after we get through that, we'll give you the poll question and try to wrap it up.
Happy to touch on those, Roger. As I think many of you know, the IRS issued just a month or so ago a new notice, 2014-67, which was ostensibly geared towards accountable care organizations and providing guidance with respect to the nature of outstanding tax-exempt debt held by one of the partners in an ACO. But really what's happened is that this was an opportunity that the Internal Revenue Service took to really rethink some of the difficult constraints that had been put in place back in 1997 with respect to Revenue Procedure 9713. It's important to note that although this was just put out and it is effective immediately, and in fact can be applied retroactively, which is can be quite helpful. So for a really thorough dissertation on this, feel free to log on to Foley's website. In the public finance section, we've got for those of you who didn't get it, there's a client alert that was primarily prepared by our tax partner, Mike Bailey, and it really kind of goes into this in some depth. But I'll touch on a few of the high points. The first is that there had been a variety of safe harbors under 9713. This one provides for a 5-year term and does not require the contract to be terminable at the tax-exempt organization's request, which is really a huge step forward when you're talking about a lot of these management contracts that had a 1 or 2 year terminable term and required that they be terminable. This really sets the stage for a reasonably long-term, stable relationship with the other party. It also provides that a variety of forms of compensation are permissible. The whole theory underlying all of this was that the beneficiary of the contract who is using facilities financed with tax-exempt bonds shouldn't share in the profit. And that is maintained but is considerably loosened up so that compensation can be fixed, it can be periodic fixed, it can be based on a capitation model, per unit model, some combination thereof. And there had been guidance about productivity awards that have been kind of piecemeal over the years. This really kind of opened that up significantly and specifically allows quality measures as being one of the criteria that can trigger a productivity award. It still can't be based on a direct measure of increased profitability, but especially since ACOs are designed in part to take advantage of the shared savings model. Shared savings is an example of productivity awards that can be used for increases in compensation. Lastly, it's sort of ironic, but the guidance with respect to a permissible ACO is helpful, but it's really kind of limited, and it consists of a 6-step program, if you will, some of which is not very well defined, but it does help, I think, get a little bit better idea of when an ACO organization will not cause a participant that's a tax-exempt entity to have their debt become taxable. So there are a few practical consequences of this, and I'll try to touch on those. First of all, we think that what this is likely to do going forward is to reduce the amount of carve-outs for private use in tax-exempt financings, because in the past, if you had a doctor's group that was occupying a building, you basically had to just carve that building out, finance on a taxable basis. If you've got now a permissible relationship with that doctor's group, you may be able to finance it on a tax-exempt basis. So When tax counsel is looking at the variety of arrangements that are out there, if the contracts are structured in a way as to be consistent with the requirements of 2014-67, it may be possible to finance a broader array of facilities. It may be worth going back and looking at existing contracts to amend them consistent with this new guidance, especially for systems that are looking at going out and financing or refinancing those facilities. Interestingly, it's likely to reduce the amount of private use being reported on the Form 990s in the Schedule K, which I'm not sure what that does other than gets the service theoretically off your back and also is a perceptual issue, but it is certainly a benefit. It's probably not a bad idea to take a look at systems compliance procedures and to update them to be consistent with the notice, because it should simplify the review process, frankly, and make it a little bit easier for those who are monitoring those contracts. And lastly, for those systems that are engaged in negotiations with the Internal Revenue Service over potential, as we call it, bad use, it may in fact affect the voluntary closing agreements with the service, because it's applicable retroactively. So it may be that this is something that's going to be quite beneficial. I think we have our poll question. So do you want to do the CLE code, Roger?
Yes, and if you're in need of CLE credit today, enter the following 4-digit code into the poll question on the screen after it's announced, and then press the submit button. The code is N as in Nancy, E as in elephant, Y as in yellow, W as in white. N-E-Y-W. That is N-E-Y-W. And again, if you're seeking CLE credit for this session, please complete the polling question by entering the code that was just announced, N-E-Y-W. And we're going to leave it open briefly. And for those of you in Kansas, New York, and New Jersey seeking CLE credit, in addition to the polling question, you need to complete the attorney affirmation form and return it to Zuleika Rahim, who can be reached at ZRAHIM at Foley, FOLEY.com, immediately following the program. Again, that's Z as in zebra, R as in Roger, A as in apple, H as in I as in indigo, M as in Mary, Zrahim at Foley.com. All right, David. I think you can continue on.
Everybody's got their CLE credit squared away. We'll talk briefly about a couple other initiatives in the past year that I think are very likely to affect us going forward. The first is the SEC has really stepped up its enforcement actions in the municipal market, and that's not likely to cease. There are two commissioners that are very outspoken about their feeling that the municipal market needs to be further regulated and scrutinized. The MCDC, which I believe stands for Municipal Continuing Disclosure Compliance Initiative, closed for borrowers on December 1st. So it's behind us to a certain extent, but what that really did was, for a recap for those of you who may not have had to deal with this, the SEC announced what they framed as sort of an amnesty for both underwriters and borrowers who had potentially made misleading or incomplete statements in their official statements regarding their compliance with their continuing disclosure obligations. As you all know, when you borrow in the tax-exempt market, the underwriter is required to get a borrower to sign an agreement to provide ongoing disclosure on an annual basis along with event notices. And there has been a fair amount of discussion about whether or not people are actually complying with that. And I think those of us who've been in the market for quite a while know that in the last few years there's been a great deal of attention paid by all parties to this. And I think what you're really seeing is people are cleaning up their act. And this was the SEC's shot across the bow. What's likely to happen going forward is that when the SEC discovers that borrowers are still making incorrect statements in their official statements, for example, saying that they've fully complied with their continued disclosure requirements but have failed to do so, the penalties are likely to be considerably more severe. There was an example of a school district in Indiana this past year that had not filed any disclosure for, I think, a 5-year period. They went back out into the market. Their underwriter clearly did not look at Emma to see if there had been any filings made. The official statement said they'd complied fully. They'd filed nothing. The SEC came in and basically slapped them on the wrist and said, don't ever do it again, and they filed and settled the case. I think it's quite likely that you're going to be seeing significantly higher penalties, including monetary penalties, and perhaps some kind of bar from the market. There's a recent case in Illinois where the SEC brought an injunctive action to stop the city from issuing debt, and then the city settled with the SEC, and the SEC basically borrowed the city from further access to the market unless they hired outside disclosure counsel to vet their disclosure. So that's a long way around of saying disclosure is going to continue to be an issue, and it behooves borrowers to pay close attention to both the disclosure in their primary offering document, the official statement, as well as be sure that they maintain good disclosure policies and practices going forward. For annual, so many healthcare providers file for quarterly disclosure and event notices. So I have a note up there about policies and procedures. The SEC has, in almost every one of its recent actions, imposed a condition on the borrower that they adopt policies and procedures that include designating an official who is responsible, undertaking training, and clearly laying out what kind of disclosure needs to be made. So that is not going to go away. The other piece of disclosure that I wanted to raise up, it relates to the direct placement market. Standard & Poor's has gone on record as saying that if any entity that it is rated by Standard & Poor's has privately placed debt, that Standard & Poor's will require them to disclose on Emma or otherwise publicly disclose the covenants and material terms and conditions of those privately placed obligations. The other rating agencies have not yet matched that, but I think that's something that is an important wrinkle on the trend for these private placed debt issuances, is that it affects your publicly held debt as well. Those credits are terribly important, and the institutional investors really want to see what the underlying credits look like. Lastly, the municipal advisor rule.
David,
yeah.
David, excuse me. Before we move on, I just want to let the audience know, if you do have questions, please use the Q&A widget on your screen to ask questions. There's not an ability to ask a question live via telephone. So if you do have questions, please feel free to use the Q&A widget.
So the last thing I'm going to touch on, and I'm going to touch on it very briefly, is the municipal advisor rule. This is another gift of the Dodd-Frank Act and became effective on July 1st. It requires that all municipal advisors register with the SEC and the MSRB. But what it's really done is that it limits the scope of advice regarding certain kinds of things, which especially relates to the issuance of municipal debt and investment of the proceeds of municipal debt, in a number of ways by other market participants. This is especially significant for the investment banking community, but it really does affect all of us. It includes bond lawyers and engineers and trustees and a whole lot of folks that will be sitting around the conference room table, either literally or figuratively. There have been a fair number of folks who are concerned that this was going to dry up the flow of information. But there are a couple of ways to maintain those open channels. The one that is most often used is the IRMA exception, which stands for Independent Registered Municipal Advisor. Borrowers that have retained an independent registered municipal advisor can let the market know, either selectively or through a blanket posting on their website, that they've retained such a professional, and then market participants that wish to provide what would otherwise be impermissible advice may provide advice to that borrower and to their municipal advisor as long as they comply with a few simple requirements. The reason this really has a lot of teeth is that if a market participant provides advice to a borrower in the course of seeking to become employed, for example, as an underwriter, they may be barred from serving as an underwriter on that financing, which is obviously a real penalty for the underwriting firm, but is also can be a real problem for the borrower. So it's worth making sure on all sides that rule is people are paying attention to that. And I'm going to jump off because I'd like to leave a little bit of room for Q&A. And if we have no Q&A, then I know Roger well enough to know that he's very good at asking questions.
Well, right now we don't really have any questions that are out there, but what I'd like to do, because we do actually have we've got about 3 minutes left. Jim, Chris, David, I'd like each one of you, if you could wrap up here, give us kind of some closing thoughts of what you think folks that are engaged, whether they be providers or whether they be advisors or they be payers or physicians, what they should be thinking about in 2015 and really expect to see and or do. Jim?
Roger, from my perspective, I think the capital market environment that Chris described creates a really kind of amazing opportunity for healthcare systems that have to make important strategic decisions, because if you think about the long-term capital cost of big investments that need to be made, they're much lower given our interest rate environment today than they would be in a more typical environment. And I think the uncertainty that Chris talked about and that others have referred to have caused a lot of healthcare systems to be, very kind of cautious about really big strategic decisions. But I think this is the environment where people really need to think through the next 10-year strategy, and I think the capital markets are such that for those organizations that have defined that strategy and have the courage of their convictions, it's a great opportunity to make really bold moves that will have a long payoff.
Thanks, Jim. Chris, if you could give us a minute or two of your thoughts.
Sure. Just to wrap up, I think building on what Jim said, unlike in sort of a typical interest rate environment where rates are sort of in a mid-long-term average, with them being as low as they are right now, it ends up meaning that it becomes kind of an important driver in overall strategic and financial management rather than just a consideration. So kind of to augment what Jim was saying, I think it's going to end up meaning over the course of 2015 that people will either look to consider accelerating things they were thinking about doing down the road, whether those are new projects or, more importantly, perhaps organizational structural considerations that they might accelerate rather than doing them as they might fall naturally in a more typical environment. And as a result, it sort of reshapes priorities to take advantage of what is a pretty, what will probably, at least in the first half of 2015 anyway, continue to be a pretty impressive market to enter.
And David, do you have any final thoughts?
Yeah, I think there's a couple things I'll note that we've touched on, but I think we see these happening because of the way the markets are. First of all, I'll reemphasize that taxable debt is something that we're seeing a lot of, and it ties up very nicely with a lot of the strategic considerations. IT investments are incredibly expensive, and yet they have a very short useful life. It can be extremely difficult to match that up with the requirements of the tax code. And so what we're seeing is, with taxable debt being at fairly low rates, it makes a lot of sense to go out with taxable debt to upgrade the IT infrastructure. Second, I think there's been a lot of speculation that rates are going to be going up. It makes sense for folks to prepare to think about that, and one of the strategies is to be looking at variable rate debt as a way of dealing with that as rates start to rise. But until they do, it does make sense to continue to take advantage of the low rates. In terms of direct placements, we touched about this a little bit, but one of the things to be aware of is that the covenants that can be demanded by banks are sometimes very, very different from what the public markets are requiring, and those tie in significantly with what you've got outstanding under publicly offered debt. So it's important to harmonize those and to be aware of that. One of the difficulties of these open MTI structures is that you find that each series of debt can have a radically different set of covenants, which can make compliance a little bit confusing. And lastly, I'll just reemphasize how important it is for borrowers in the tax-exempt market to maintain their disclosure. It's extremely important that those disclosure practices and procedures be carefully adhered to and the filings be made in a timely manner.
Excellent. Thank you to all of our panelists. We greatly appreciate your time and effort, Jim, Chris, David. We at Foley and Lardner hope that you all enjoyed this and really got something out of it, and it prepares you for 2015. You can find the bios and contact any of the panelists through their respective websites at PFM Group for Chris, at Kane Brothers for Jim, and for David and me at www.foley.com. Thanks very much, everybody, and have a happy holiday season.
Thanks.